diet and many medications which can lead to the increased uric acid level. Hyperuricemia is mainly asymptomatic. Its prevalence is 5 to 8% and only 20% of them would develop gout attack. Its onset in male is usually in 30 years of age. In post-menopause female, it is seen more common because the estrogen hormone is considered to be uricosuric. Duration is usually 10 to 15 years. The hyperuricemia is there and the clinical disease starts later. 90% are under respirators and 10% are overproducers. 50 to 60% will have recurrent attack after their first attack, and 80% within 2 years have the second attack. And 2 to 7% will not have any attack even after 10 years. So, what is the normal level of uric acid? It's 7 mg per deciliter at 37 degrees centigrade because it is the level when uric acid is soluble in our body fluid and it doesn't accumulate anywhere. Beyond that, it has tendency to accumulate at different part of the body, soft tissue, joints and all that. And as the level increases, the incidence or the tendency to have acute gout or gout flare increases. These are some of the causes of under-excretion and overproduction. Most of the causes are intrinsic factors like decreased renal excretion, previous gout, some drugs, and in overproduction if there is increased cell turnover or some drugs or the renal involvement, and ethanol is a factor that can cause both under-excretion and overproduction. It is caused by the deposition of uric acid in and around the joint at the renal, maybe in the kidneys, causing urate nephropathy. It is a byproduct of urine metabolism. Urine is converted to hypoxanthine, benxanthine, and then uric acid, and it is catalyzed by the xanthine oxidase enzyme. With the balance, when the balance of dietary intake, its breakdown, and excretion is interrupted, then hyperuricemia occurs. So gout is a disease of royals. It's a royal pain, and the reason we will learn gradually in my visual slide. Because of the increased meat intake, increased alcohol, lack of exercises and obesity which is more prevalent in this class. Because of the royal pain, the market has become huge and the medicines are getting expensive and it has raised, the prices are raised tremendously over past 2 decades. So the natural history, we all are aware of it, that initially it's asymptomatic. Then they will have acute attack of gout. There might be a period, or there usually is a period when there is no attacks of gout, and many of the patients tend to forget that they even had some attack previously. And later on, as they grow older, there are recurrent attacks, and finally, if they left and untreated, there will be chronic locational gout. So clinically, gout is very easy to understand, very easy to pick, only if we are alert and we are taking detailed history. It is very important that the patient should be taken, the history should be taken carefully and examined carefully, because they usually affect the single joint, usually lower torso. There is rapid onset of pain and inflammation, and it is exquisitely tender within 24 hours. Attacks are separated by intercritical period. Now this picture, it can mimic many other conditions, as Dr. Sami told us, that pseudo-gout can also affect first metatarsophalangeal joint, again, sarcoidosis, cellulitis, septic arthritis, they should all be in the differential. And the confirmatory test that can only assure you that you are in the right diagnosis is the synovial fluid aspiration and demonstration of needle-shaped crystals of monosodium urate, which are negatively birefringent in polarized compensated microscopy. And we at Yamata National Hospital, we have polarized microscopy available in our own department, and we check for these crystals in our department. This is what Dr. Sami was saying it is not being done anywhere, so we do it regularly. So the only thing that the student need to remember is that we have, if the crystals are parallel to the axis of polarizer, they are yellow, and if they are perpendicular, then they are blue. This is what happens when you change the axis, and if the crystals are behaving like that, then you are almost 100% sure that the patient has got these crystals positive. Now, if the small joints are involved, we might not be able to aspirate fluid, so we will have to rely upon the clinical diagnosis only, because uric acid can be normal in up to 30% of the patients. Now there is also confusion, what is acute and what is chronic, because the patient who's got chronic gout will have acute attacks intermittently as well, and many of the physicians or the orthopedics, they also think that only chronic gout need urate lowering therapy. So the new recommended terms are gout flare rather than acute gout, intercritical gout, and chronic gouty arthritis. The treatment is similar, which just Dr. Sami elaborated as in pseudo-gout. There is nothing different. NSAIDs, historically, the physicians and GPs like indomethacin a lot, but the research has proven that each NSAID can have similar efficacy. Corticosteroids can be used both intraarticularly or orally if needed. Oral colchicine is usually affected in if started within 24 to 48 hours, it removes the attack very quickly. But the historical approach was given in the high dose, and I always love to quote this sentence to my students that patients often run before they walk because it causes diarrhea and they have to run to the toilet. And lastly, it's anaphylactic. So it was shown in agreed trial that low dose colchicine was equally effective, and the side effect profile was much higher in high dose. So the ULAR recommended to reduce the dose of colchicine in patients with acute gout. Similarly, when we talk about anakinra, it's not available in our region and it's pretty expensive, but the research showed that if the patient is given 100 milligram of anakinra for 5 days daily, then the pain score, the inflammation score was dramatically improved by the 5th day. Now when we talk about treatment strategy, and we have already learned about the pathophysiology, the most common drugs which are used are allopurinol and febuxostat, and they inhibit xanthine oxidase enzyme, which is the catalyst for conversion of hypoxanthine to xanthine and then to uric acid. But the confusion arose that when there was a care study which showed that urate lowering therapy, especially with febuxostat, it is associated with cardiovascular risk, and the data, although it showed that there is no difference in composite cardiovascular endpoint, but there was a trend of high cardiovascular mortality and deaths in the patients who had febuxostat. Later, there were fast trial and large real-world data that said that the death mortality or cardiovascular outcome was similar in allopurinol and febuxostat group. So it was rather reassuring. When we talk about diet, it's very difficult to ask anybody to leave what they most love to eat, like sugary, like I love sugar, I love cakes. I cannot stop it for whole life. We love tikka and we love barbecue. We cannot leave those things for life, but we need to tell them that they should have a healthy diet along with weight reduction as a target, and we should have a healthy diet. The things that they need to avoid are the organ meat and the alcohol actually. So another misconception is to use diet modification to reduce uric acid level in our blood, but the main important target or the main factor of doing that is to reduce the triggers that can trigger your gout attack. So we should ask them to avoid sugary drinks, high fructose corn syrup, alcohol because it reduces the renal excretion as well, organ meats which involve liver, the brains and kidney, and then lean meats. I'm not sure how many people are able to do it nowadays, but still the goose, beef, venison, these are all high in purine content, and that's why it's called rich man's disease. Seafoods, they are also very expensive, scallops, the codfish, tuna and all these. Red meat, these are all high in purine content. But at the same time, there was a small data that showed a U-shaped association of serum urate levels with mortality in sub-observational studies. Now it was really confusing that if you reduce the uric acid level, it was beneficial initially, but later on the mortality rate rose. Association was there with worsening of neurological outcome, and there was also a question that whether there is increased cardiovascular risk factors are present with the low level of uric acid. Now I will briefly go through the 2020 ACR treatment guidelines. The recommendation of starting urate lowering therapy is similar as in the past, that if the patient has got one or more subcutaneous tophi, radiological damages associated with gout, frequent gout flare, then you can start with urate lowering therapy. And I fail to understand that with rheumatoid arthritis, we are planning to start treatment as early as possible to prevent all these things, radiological damages, poor outcome in the patients. And but with gout, we are waiting for development of tophi and radiological damage before starting urate lowering therapy. But you can start urate lowering therapy after first attack if the patient has got renal damage, uric acid level is more than 9, and there is urolithiasis. They recommended against urate lowering therapy if there is only asymptomatic hyperuricemia without any prior flares or subcutaneous tophi. So the first choice should be allopurinol. Even if the patient has got stage 3 CKD, allopurinol and febuxostat are recommended over probenecid. We do not want our patient to have urolithiasis. Starting doses should be lower to prevent the risk of flare in the patients. Allopurinol 100 mg per day, febuxostat less than 40 mg, and then subsequent dose titration. They also recommend HLA-B5801 testing, which is not available, to avoid the risk of allopurinol hypersensitivity reaction, which is hypersensitivity syndrome, which is a life-threatening condition. Now, initially, when I was a student, I was taught, and then we kept on practicing that urate lowering therapy should not be started during acute attack because it might flare the attack. But now the recommendation is that if you start it during the attack and there is evidence that it will help in controlling it earlier. Concomitant anti-inflammatory therapy is also recommended because if you are starting urate lowering therapy, the risk of triggering the flare rises much higher. So you can start with NSAID, which obviously we are not going to give them for long. We can also accompany the patient with colchicine in at least 3 to 6 months till they achieve a steady uric acid level, and prednisone if needed. Finally, we also have the treat to target approach. And I don't understand how you can get it once the patient is already has got the erosions and the joint damage. Duration of urate lowering therapy was also indefinite. They recommended that you should taper it as soon as the uric acid level is like less than 6, and then you gradually taper the dose and keep the patient on lower dose of urate lower therapy for life. But if the patient is not responding, its uric acid level is not coming to 6, despite xanthine oxidase inhibitor, you can add another xanthine oxidase inhibitor or switch to a better class. Management of lifestyle, we have already learned about it. It is a primitive factor to reduce the triggers. Now it continues to be an ongoing problem. Just because the people either over-treating gout, over-treating uric acid level, or we have seen patients who have got frequent attacks of gout and who do not have urate lowering therapy on their prescription slip. Many times they are underutilized. Obviously, when you have to ask the patient that you have to get the most precious thing in your life, that is food, that they love, then their compliance will be always questionable. There are many unanswered questions, meaning whether renal disease is the cause or the effect of the hyperuricemia, metabolic syndrome and cardiovascular risk So this is my institution where I learned rheumatology, and I've been practicing rheumatology there for more than 15 years now. Thank you.
Thank you so much, Dr. Taira Naveen, for this amazing presentation. The last speaker for this session is Professor Dr. Samina Ghaznavi, who is a current president of the Pakistan Society for Rheumatology. Professor Dr. Samina will be speaking on osteoporosis and